You would like to think that these Medicare Advantage plans, the way that they're profitable and making their money, is because they found a way to keep their population of patients healthy. You would love to think that that's the case, and they're striving for that. And it's a great incentive. You can generate profit by keeping your patients healthy and out of the hospital. It's going to cost you less to care for them. And that's a great notion. But in reality, what we find is that these payers are very profitable, not by keeping their patients healthier, but by delaying and denying payment to the providers. So they delay payment through, like I mentioned, prior auth process. They create all these barriers to actually getting the patient through and into the health system. But then they also deny payment or downgrade payment by operating in, Chip, you referred to them as the gray areas, and they really are that. And you know, the areas that are more subjective in nature. So think things like medical necessity, utilization management, independent physician decision-making, for example.
Welcome to Hospitals in Focus from the Federation of American Hospitals. Here's your host, Chip Kahn.
Today, over half of Medicare's beneficiaries are enrolled in Medicare Advantage. That's nearly 35 million Americans. Medicare Advantage, or MA as it's known, promises efficiency and added benefits in comparison to fee-for-service Medicare. But behind the curtain, those same plans are delaying or impeding care and frequently denying payment. And who pays the price? Providers and the patients they serve. Here to unpack this today for us is Brad Gingerich, Vice President at Ensemble. Brad knows this world inside and out. He spent years helping hospital systems navigate managed care and revenue cycle challenges. Brad, great to have you with us today.
Thanks, Jim. Happy to be here. Appreciate all the great work that you and the Federation are doing.
Well, we really appreciate what you do for health systems every day and the patients they serve, Brad. Just to get started, let's sort of lay out a foundation for our audience. Obviously, we've got people at all levels of knowledge about Medicare Advantage, or MA as we're going to refer to it here. Can you just explain sort of how MA works and for the beneficiaries and how that coverage works, and then we'll get into some other issues about how the insurers who provide that MA use it.
Sure. Yeah, happy to, Chip. Thank you. So Medicare Advantage, Medicare Part C, is really just a privatized version of traditional Medicare. So once a citizen is eligible for Medicare, they really have an option. And that option being, do they want to stick with traditional Medicare, or do they want to opt into a privatized form of Medicare? Typically, the privatized version, as we refer to as Medicare Advantage, is at no additional cost to the patient. It's funded by CMS with the same cafeteria dollars that they otherwise would use for fee-for-service. What's somewhat unique in this situation, to make it appealing to patients, is that the benefits being offered in the privatized Medicare Advantage space can oftentimes be richer than traditional benefits under Medicare. So this can create an appealing option to patients, particularly when you consider that the cost to opt into a privatized plan is typically no cost at all to the member.
So you're describing a situation where upfront, and particularly for lower income Medicare beneficiaries or Medicare beneficiaries that are eligible for Medicare and for Medicaid, that this can be an advantage to them in terms of out-of-pockets, in terms of belonging to a health plan that supposedly will provide them more health maintenance-like care, at least in terms of the sales of that product. But at the same time, a certain number of beneficiaries are going to need care, and that's sort of the other side. And there we see, and I referred to in my introduction, there are common strategies to delay services, to impede care, and then ultimately at the other end, even to deny payment to providers or clinicians who've served a patient. How does this all work in terms of the patient and in terms of those trying to serve that patient?
Yeah, so that's a great question. With Medicare Advantage, really the privatized insurance companies serve largely as a gatekeeper, a gatekeeper to care. They do that by standing up provider networks. So if I want to compare this to traditional Medicare, by and large, all providers in our country accept Medicare with very, very few exceptions. In the case of Medicare Advantage, however, they go out and assemble networks of participating providers. A part of that is getting authorization. So you actually have to go through the plan to authorize the care. That requires a physician to write a referral, typically, warranty or justifying the need for the care. And then you have to go to the Medicare Advantage plan to actually agree that you do, in fact, require that particular service. And then if the Medicare Advantage plan agrees, they will grant that authorization. This is very different than traditional Medicare, in as much as traditional Medicare, by and large, does not have an authorization process. Very few exceptions, just in things that may not actually mean a medical procedure, thinking things that might blur on the lines of, say, a cosmetic type procedure. That's really where you're limited on the prior auth process under traditional Medicare. However, Medicare Advantage patients are subject to all these different rules and restrictions, which again serve as a gatekeeper to the patient ultimately getting the care they need, and the providers getting paid for the care they render.
So there's an incentive there for the plans to try to keep utilization down because patients, if the patients don't use their coverage, then the plan obviously can keep the money, and the beneficiary is sort of in the middle. What are these gray areas in terms of the rules that plans are using, frankly, to make it more difficult for patients and I think potentially to interfere with that incredibly important physician-patient relationship, where the physician, is both the broker and the navigator for the patient through the system when the patient is ill and needs care.
Yeah, that's a great point. So the plans, you would like to think that these Medicare Advantage plans, the way that they're profitable and making their money is because they found a way to keep their population patients healthier. You would love to think that that's the case, and they're striving for that. And it's a great incentive. You can generate profit at keeping your patients healthy. Now, the hospital, it's going to cost you less to care for them. And that's a great notion. But in reality, what we find is that these payers are very profitable, not by keeping their patients healthier, but by delaying and denying payment to the providers. So they delay payment through, like I mentioned, prior auth process. They create all these barriers to actually getting the patient through and into the health system. But then they also deny payment or downgrade payment by operating in, Chip, you referred to them as the gray areas, and they really are that. Any of the areas that are more subjective in nature. So think things like medical necessity, utilization management, independent physician decision-making, for example. Two physicians can have two differing opinions on a matter. One of those physicians happens to be at the Medicare Advantage plan. That gives grounds for disagreement. And the Medicare Advantage plans will, based on that disagreement, choose not to pay claims. They will actually deny the claim. And again, it's in these areas where it's very subjective. There's no really black and white prescribed rule from what is medically necessary, not a case if this is more of an art than a science in many instances. And so that does leave a lot of room for disagreement. And it's within these margins and these gray areas where the Medicare Advantage payers have been very successful in promoting our payment, particularly if you compare it to traditional Medicare. A typical provider collects around 88 cents on the dollar compared to traditional Medicare for the same patients. And it's through these denials, downgrades, and things you might make sure that we're really seeing it rise up to that amount in aggregate.
So the patients are frequently not getting the care they need. It could be an admission to a hospital. It could be, if they're in the hospital, then an admission that would be paid for to a rehab hospital or other kind of post-acute setting. So that's the effect directly on patients. Now, clearly, in terms of the revenue and resources that a hospital or other provider needs to provide and pay for the services and pay, keep the lights on and pay the nurses and others who provide the critical care, if there's either delay or denial of payment, that has an effect. Let's take a deeper dive and talk about an example where this is the case. And I'll lay something out and then let you respond. So many years ago, and I was involved in this in negotiations that the hospital field had with Medicare on the fee-for-service side. There was this issue of, when is a patient, when they admitted through the emergency room, when do they become an inpatient rather than in some kind of observation? And with many of these senior patients, they'll come into a hospital and pretty rapidly be sent up to the floor and basically be an inpatient. But there was this gray area for Medicare in terms of when they went from observation, sort of waiting or being observed as to what kind of care they would need in the emergency room, versus being on the floor and being receiving what the kind of care and the kind of intensity that inpatient patients do. And so we came up with a compromise with CMS, that this thing called the 2 midnight rule, that if a patient was in the hospital for 2 midnights, or basically 48 hours, that Medicare would consider that inpatient. And it was a clean policy that made it very clear. It's the physician serving that patient that helps make this decision. That rule is in fee-for-service Medicare, but it isn't a rule for the other part of Medicare, for Medicare Advantage. Now, we believe that it's part of the benefit, and the Medicare Advantage ought to be doing it, but they're not. They're doing other things. So, can you describe how this issue of observation admissions versus inpatient admissions works? And then I'm going to ask about a specific health plan. Let's sort of start with your understanding of what happens on the health plan side in reality, regardless of the fee-for-service agreement that the hospital industry serving patients have with CMS about how this should be treated.
Sure. Well, CMS did offer guidance actually in January of 2024 that they expect Medicare Advantage plans to operate the same as CMS with respect to 2 midnight rule and the presumption that the patient will be an inpatient. And they go on to say that if they expect the patient to require hospital care that spans 2 or more midnights, the Medicare Advantage plan should treat that just like traditional Medicare does, and deem that an inpatient. What we're finding in practice is that the Medicare Advantage plans are not adhering to this really in any regard. The reason being is there's a bit of an area, a gray area, as it were, left to dispute, and that is the determination on whether or not the patient required hospital care to span 2 midnights. And so the magic word there is require. And who's to say the patient couldn't have gone home? And well, in this case, it was the attending physician who stated the patient couldn't have gone home, or they would have discharged him unless there's a clear non-medical reason that they didn't. However, the Medicare Advantage plan takes a dissenting view on that and thinks the patient could have gone home. They think services could have rendered at an outpatient setting. And therefore, despite the fact the patient spanned 2 midnight, the payer still stands on that notion that the patient could have been discharged, and therefore the payer will allow you to rebill it as an observation if you so choose, because they will willingly pay the observation rate, but they will not pay the inpatient. And we're seeing that more and more. And I'll just go one bit further on this point. I mentioned the gatekeepers before. In the actual process within a hospital, when we want to admit a patient to an inpatient status, we provide a notice of admission to the payer, the Medicare Advantage plan. We inform them that we're admitting the patient. They come back with a response. Either they agree it meets inpatient criteria, or they do not agree and the patient should be in observation. Based on this real-time gatekeeper process, I find that providers actually admit Medicare Advantage patients at a much lower rate than they do traditional Medicare. Like traditional Medicare, you don't have to go through a case management department at a payer to agree that the patient meets inpatient status. So keep in mind that hospitals are admitting Medicare patients at a less, for lack of a better term, aggressive rate than they do traditional Medicare. So common example, I see a traditional Medicare patients that span 2 midnights. Typically, you'll see around 90% of the time they're admitted. Medicare Advantage, those same patients get admitted on average more around 80% of the time. Right? So they're even admitted at a lower clip. Even despite this, Medicare Advantage denies a 3.6 times greater than even commercial claims, and almost infinitely greater than traditional Medicare because you're not being denied whatsoever. So it's astounding that through the gatekeepers that I keep referring to, we're already self-censoring, if you will, in terms of taking the path of least resistance and just going for an observation rate. And even despite that, the payers are still denying at an extremely aggressive rate. So the providers are being conservative, and still being denied at a very extreme rate by this Medicare Advantage plans.
So let's talk about one plan, Aetna, that thinks they're helping hospitals by adopting their own version of a policy here, a correction here, to deal with this issue of observation versus inpatient, which on the one hand, it gets us really into the weeds in terms of discussing it, but frankly, it's a real bread and butter issue for hospitalizations and the important revenue that hospitals need to be able to have the resources to provide the services. Let's talk about what Aetna's planning to do and how they see that on the one hand as a solution. I'm concerned that it's a little bit in this gray area, potentially.
Yeah, and you're right, Chip. It is in the gray area. And this will get a little into the weeds for some, but I think it's important to show how this, the devil is in the detail. Here within this gray area, this is how some of the payers are doing it. So Aetna, for their Medicare Advantage product, has announced a new policy that they have since delayed until January 1st. Originally, it was supposed to roll out November 15th. The policy is such that any patient that it presents to the ER and is admitted and spans at least 1 midnight, Aetna will automatically approve that patient for an inpatient level of care so long as the provider admits the patient to inpatient. They will not challenge it whatsoever. You will not have to prove medical necessity or anything along those lines. However, what Aetna will do is they will unilaterally make a determination on the level of severity of that admission. And if they deem this to be a lower level severity, essentially, if they deem this to be the equivalent to an observation case, they're going to pay you what they've calculated to be effectively the average observation rate. Now, the reason this is a sneaky policy is, well, it does a lot of things. One, this becomes a payment dispute, not a medical necessity dispute. So Aetna is not denying them grounds of medical necessity. They're not doing that at all. Say, we agree with you, the patient should be admitted. They are instead making this a payment dispute. And they're saying, this is the amount we want to pay you for this admission. And if you take exception to it, you can certainly challenge that. However, it's not a formal medical necessity denial in a formal medical necessity appeal. And we have very different appeal remedies in the Medicare Advantage regulation for medical necessity denials than we do what I would call payment denials or technical denials, which this is. And so, for example, we are losing peer-to-peer rights. So a peer-to-peer review is when a physician advisor from the provider contacts the physician advisor from the insurance company and to have a clinical discussion about the merits of the patient being admitted. Under the new Aetna policy, you no longer have the opportunity to do peer-to-peer reviews. Instead, you can have what they're calling a physician discussion, which sounds like the same thing, but there are technical differences. Our appeal remedies are different. Our first level, second level appeal remedies are different, as this is no longer a medical necessity denial. So what it's doing is kind of in these gray areas that are not clearly specified, Aetna is implementing payment policies to usurp medical necessity decisions. And they're being so bold as to do it as they're actually using minimum care guidelines to make the payment determination, even though CMS has come out and explicitly said minimum should not be used for coverage and care determinations. Well, Aetna's saying that fine, and we're in compliance with that. We're not using it for coverage and care determinations. There's no dispute about medical necessity. We're utilizing minimum care guidelines to determine whether this is a low severity, and if so, pay. So they're shifting out of medical necessity disputes and over into technical payment disputes, where on the provider side, our remedy to overturn those denials is much less. We don't have the same recourse, legal recourse, regulatory or otherwise, or appeal infrastructure to be successful in those.
Well, I mean, the devil is in the details, as you described. And from my years of experience in this, you get into these details, but at the end of the day, it actually does directly affect physician decision-making for their patients. Let's move away from the MA side, because this isn't just an issue of Medicare Advantage or the Medicare program. This is also a major issue for the private sector coverage for the 165 million plus Americans that are covered by employer coverage, as well as those 24 million who are covered in exchanges across the country by private insurance. And let's talk a bit about something that Elevance, a Blue Cross plan that is in many states across the country, a policy they're coming up with regarding hospital care and the billing process that would have a critical effect on hospital payment, but also ultimately boomerang back on patients because of the effect of this. Can we talk a bit about that and describe this Elevance policy?
Sure. Yeah. So Elevance recently announced a policy that's going to be rolled out in several states, where really what they're attempting to do is curtail out-of-network utilization, particularly amongst what we refer to as invisible providers. So these are the ologists, if you will, within a hospital. So anesthesiologists, radiologists, hospitalists, ER physicians, all of the physicians that support the operations of a hospital. But when you seek to go to a hospital, you're typically looking to see if that hospital is in network, and rarely does the consumer go down a laundry list to see if the emergency room physicians are participating, radiologists, et cetera. And so there is still inevitably a certain amount of surprise out-of-network utilization. Well, during Donald Trump's first term, he signed into law the No Surprises Act, which actually protects patients from this very issue. He invalidates a patient if they're in a medical emergency situation, they didn't have the proper notices that they were seeking treatment from an out-of-network provider. So patient protections are already put into effect and enacted by law. And in fact, part and parcel to that is a dispute resolution process. So if and when a provider is out of network with the payer, they treat a patient on an out of network basis. And if the provider and the payer cannot agree mutually on a reasonable payment for that service, the patient does not get pulled in the middle of the balance bill. Instead, the payer and provider enter into independent dispute resolution. And there's a baseball style arbitration. An arbitrator chooses one of two numbers. The provider puts forth an offer, the payer puts forth an offer. The arbitrator, based on all the information presented, chooses one of those winning offers. That's amount that ultimately gets paid. The claim is done. The patient does not get balance billed, and it's resolved. Well, as data would suggest, 85% of the time in these IDRs, independent dispute resolution process, it was found that the payer discounted the claim too aggressively and short paid the provider. So the provider brought it to the dispute resolution. The two parties each entered their offer. 85% of the time, the provider's offer was selected, resulting in the payer paying an additional amount. So from payer lost, provider won 85% of the time. What you're seeing is Anthem's new policy is, in fact, a response to the payers at large failing to prevail in the IDR process. Now, they might, again, do this under the guise of protecting patients, but the No Surprises Act already has done that, or under the guise of trying to protect self-funded employer spend, right? Because they would argue that these out-of-network claims, they're paying too much for the IDR process, so they want to create a penalty on that. So, they're trying to do it under the guise of a benevolence and trying to protect the patient or the employer. But the reality is payers are losing in the IDR process because providers are not accepting the lowball offers that they're making. Arbitrators are seeing that, agreeing and siding with the providers. And now it's creating a situation, and I didn't explain the policy, but what the policy is Anthem is suggesting that they will put a 10% payment penalty on a hospital for their hospital claim if any portion of that claim professional component was rendered by the out-of-network physician. So if you think about that, hospitals have little, if any, control over contractual ability of independent physicians who might operate in their facility. In fact, it likely creates a conflict of interest to try to compel them to contract with payers and try to have a hospital interfere with those business relationships. But lastly, what needs to be known is many hospitals have to rely on third parties to operate there. So they may not be able to staff and have an ER group manage that. So they'll rely on a third party physician group to provide that ER services. And it may be that physician group was not able to achieve a sustainable contract with an Anthem or a United. And as a result, they had to make a tough decision to go out and out. As a result of that decision, a hospital now is going to be penalized. And if that penalty is great enough that the hospital is going to want to entertain getting in the middle of that professional group's negotiation with that payer and try to compel them to negotiate, well, at some point that's going to come back to the hospital, because in that scenario I just described, many times these hospitals, these providers need to subsidize those physician groups because of payer mix or otherwise, just allow them to operate and staff the ER. And so the way a subsidy works, we're already backfilled just the deficit. That deficit is going to grow because you're going to force that physician group to sign an unfavorable contract with an Anthem. You're just going to increase the subsidies that ultimately a hospital has to pay that physician with the visit. So it's in a very indirect way, just a tax back on the hospitals at the end of the day.
Yeah. So in the guise of helping the patients, having all the people the patients are served by in the hospital and network, instead what they're actually doing is, at the end of the day, probably increasing the cost of the hospital to provide the service, because they're going to have to subsidize the physician. When any physician who's out of network right now, the patient is protected against an out-of-line balance bill, because there's the No Surprises Act, which limits what the physician can charge the patient. So in a sense, by apparently trying to solve a problem, they're actually creating a new problem for the physicians and for the hospitals. Sort of getting to closing out our conversation, Brad, can you just sort of outline, to sum up, the real world consequences for patients, providers, clinicians, and hospitals of the insurance techniques, the bending of the rules that are being experienced now, really throughout the system, whether for Medicare patients, Medicaid patients, many of whom, 70% of whom, are in managed care, or the private employer insurance, or even individual insurance patients who are also in managed care.
Yeah, so the real world is all of these pieces are interrelated, and particularly when you think of some of these insurance companies, and we've named a few of them. So let's just Anthem, but they're not unique. United is another good example, or Aetna. These are all very diversified organizations, and by that I mean they offer exchange products, they offer Medicare Advantage products, they offer commercial products, and they offer the Medicaid. But all those organizations just have one ultimate bottom line, that they're largely accountable to their shareholders on. What that means is they have the ability to think of something fungible. And so the best example I can give of this is this. In our country, commercial insurance pays on average 2.5 times Medicare. 2.5 times what traditional Medicare pays. Medicare Advantage pays providers about 90% of what traditional Medicare pays. Despite on paper, it says they should pay them 100. Through all the things we talk about, the gray area, the margins, how they deny care, erode your revenue, all that. Traditional Medicare pays around 90 cents on the dollar. Commercial, again, is at 2.5 times that. Commercial insurance is really subsidizing all of it. If you think about it. So I'm a managed care professional, and if I want to negotiate a contract with one of those diversified entities I just explained, I might come to a United or an Anthem and take exception to the fact that I'm getting 90 cents on the dollar from Medicare Advantage compared to Medicare. And I might make a really big deal about that and threaten to terminate Medicare Advantage contract. Right. And eventually the payer is going to say something to say, we understand that's the best we can do on MA. Look over here at this commercial product. We can fill that revenue need by giving you a healthy increase on the commercial product. Okay, so that sounds good to a pragmatic hospital operator, but it's not until you really realize the funding of these that you see what's going on. That commercial product, 85% of those dollars paid, that 250% of Medicare, is funded dollar for dollar by the employer. They're simply paying the negotiated rate that Anthem, United, Aetna has with the provider. But the funds are coming directly from the employer. Whereas in the case of Medicare, those funds are coming from the payer. So they will hold on to those MA funds as long as they can, because that's what flows to the bottom line. And instead, it will be more likely to concede on the commercial side. And that's no more evident than in the rates. Why? It does not stand to reason that commercial pays 2.5 times what traditional Medicare pays, and 2.7 times what Medicare Advantage pays, when commercial are the lowest cost patients we have to deal with. They're the lowest age cohort. It's a lower length of stay compared to traditional Medicare. On a all equal basis, these are the cheap. The compensation should be the lowest, but it's all based on the incentives. Those dollars come directly from the employer. The fully insured business, the Medicare Advantages, the exchange, that comes out of the insurance coffers. They fight hard to protect those dollars and not spend them, not pay them out to providers, whereas they will be more lenient with employer dollars. And that's what you see, and that's why the rates are where they are. And so when providers establish new ground within an A plan, let's say under the 2 midnight rule, if we're able to fall back revenue under that rule, you're only going to see it offset later. They're going to find a way to pull it back and then continue to see those commercial rates. And that's where we are. And at some point, it's likely going to be unsustainable. And so I think the solution is we have to hold the Medicare Advantage accountable. We have to keep it within those tranches. And Medicare needs to stand on its own. those businesses need to pay those claims, or you need to be out of business. And maybe for this long, Medicare is a better fit for many.
Brad, this has been great. I want to thank you for your insights. So I think we've peeled back the layers on how MA plans, managed care generally, are using the system, whether it's through policies like Aetna's lack of use and recognition of the 2 midnight rule, or Elevance's approach to surprise billing to ignore the law and try to leverage out of the application of the law. We've seen the ripple effect that will have on providers and patients. The bottom line, these aren't just administrative headaches. They're real barriers to care, and they're shaping the way hospitals operate every day. So this has been a great discussion, Brad, and I just really appreciate your taking time to be with us today.
All mine. Thank you, Chip.
Thanks for listening to Hospitals in Focus from the Federation of American Hospitals. Learn more at FAH.org. Follow the Federation on social media at FAH Hospitals and follow Chip at ChipCon. Please rate, review, and subscribe to Hospitals in Focus. Join us next time for more in-depth conversations with healthcare leaders.